Our next presenters, Dr. Merna Hussein, Teaching Assistant at Faculty of Medicine of Ain Shams University, and Dr. Nancy Mohamed, Teaching Assistant at the Faculty of Medicine at Ain Shams University. They are presenting a presentation entitled When Radiology Shines and Histology Approves, under the supervision of Professor Dr. Iman Houidi and Professor Dr. Riham Ibrahim from Faculty of Medicine at Ain Shams University. Dr. Nancy, Dr. Merna, you may start sharing.
Okay, good morning, everyone. My name is Nancy Abdulal, and I'm very happy to be here with you today and present this very interesting case with my colleague Merna Hussein, titled When Radiology Shines and Histology Approves, under the supervision of Professor Dr. Iman Houidi and Assistant Professor Dr. Riham Ahmed from Ain Shams University. So I'll start by telling you about the case. An 18-year-old male came presenting with ataxia and subnormal mentality. He had no relevant past medical or surgical history. Investigations were done like CBC, renal functions, and liver functions, which all turned out to be normal. A brain MRI was requested, which showed the following films. As we can see here in this T1 axial cut, we have a lesion in the left cerebellar hemisphere, which appeared hypointense and showed no enhancement post-contrast. As you can see here in T2 on the left-hand side and T2 flare on the right-hand side, the lesion appeared hyperintense with preserved cortical striations and a very characteristic striping pattern, which actually resembles the striping pattern of a tiger. The patient also had evidence of supratentorial hydrocephalus. Following radiology, the patient underwent surgical excision of the lesion, and it was sent for histopathologic examination, received in our lab as multiple tan and grayish irregular rubbery tissue pieces measuring 2.5 centimeters collectively in each dimension. Looking at the lesion under the microscope, the first thing to be noticed is how the lesion respected the normal cerebellar architecture. So as you can see here, we have the pia mater followed by the molecular cell layer and the granular cell layer. However, the cerebellar folia showed relative thickening or enlargement, if you can compare this side with this side, with relative thinning of the white matter. Looking at a higher power, we can see that the cerebellar folia are studded. I'm sorry, can you see the screen?
Yes, doctor, I can see the screen.
Wait a minute. If you look at a higher power, we can see that the cerebellar folia are studded with these dysplastic. Someone is unmuted. Sorry. The cerebellar folia are studded with these dysplastic ganglionic cells with rounded borders, eosinophilic cytoplasm, vesicular nuclei, and prominent nucleoli. The surrounding matrix resembled normal neuropil. Other features that were noticed in this lesion were the decrease in the number of the Purkinje cells. As you can see here, we have arrows pointing to one Purkinje cell between the molecular and granular layer, and normally the Purkinje cells are supposed to be arranged in a parallel line between these two layers at regular intervals. However, if you notice here, we have a Purkinje cell dropout or decrease. There's also vacuolization of the molecular layer, as well as abnormal myelination. If you notice on the picture on your right, we have abnormal fibers crossing through the molecular layer. This lesion showed no mitosis, no necrosis, or proliferation of the vascular endothelium. Putting together all these clues, like the radiologic image and the essential features that are gangliocytes enlarging the cerebellar folia, or of variable sizes, and normal neuropil, as well as abnormal myelination and vascularization in the molecular layer, we reach the diagnosis of dysplastic cerebellar gangliocytoma, or Lermie-Duclos disease, a CNS WHO grade 1 tumor, which can be associated with what is known as Cowden syndrome. After pathologic confirmation, the patient was advised to follow up for development of additional features of this syndrome, which my friend Merna will talk to you more about. So Lermie-Duclos disease is a rare lesion of the cerebellum with mass effects leading to neurological manifestations. It was first described in 1920 by Jean Lermie and P. Duclos, described as diffuse myelinated ganglioneuroma of the cerebellum, and it was originally questioned whether it is a tumor or a hamartomatous malformation. Regarding the epidemiology, as we said, it's extremely rare. It affects males and females equally, predominantly in the 3rd to 5th decades of life, and shows no racial or socioeconomic preference. The pathophysiology of the disease is not fully understood. However, it has been concluded that it's associated with Cowden syndrome, an autosomal dominant disease leading to the formation of multiple hamartomas involving all 3 germ layers. This disease occurs due to the mutation in the P10 gene located in chromosome 10, which is a tumor suppressor gene. Therefore, people who are diagnosed with Cowden syndrome have an increased risk for tumors occurring in the breast, GIT, or thyroid. That is why it is essential to follow up with these patients. Mutation in the P10 gene actually occurs in 85% of these patients. Others may have mutation in the SDHB or SDHD variant, which are shown to affect the same downstream signaling pathway as the P10 gene. So more about Lermie-Duclos, it usually occurs unilaterally in the cerebellum, but may be bilateral. It could present with cranial nerve palsies, unsteadiness of gait, ataxia, visual disturbance, and headache, and it could lead to hydrocephalus. These symptoms could occur due to the lesion in the cerebellum itself or due to the increased intracranial tension. The gold standard for diagnosis of Lermie-Duclos is MRI. As we mentioned earlier, it shows a hypointense lesion in T1 and a very characteristic tiger stripe sign in T2. Genetic testing for P10 mutation could also be done, but it's not necessary. Differential diagnosis includes ganglion cell tumors such as gangliocytoma, ganglioglioma, and infiltrating gliomas with trapped Purkinje cells. These tumors differ, for example, though, in radiology, like ganglioglioma, which shows a cyst with mural nodule and enhances post-contrast versus the picture shown in Lermie-Duclos disease. To treat these patients, asymptomatic cases could be managed only by observation. Symptomatic cases could undergo microsurgical removal, but complete excision in these cases may be difficult due to the ill-defined margins of the lesion. If the patient presents with hydrocephalus, initially the focus may be directed towards treating that first through shunts, and then followed by removal of the tumor. The prognosis of this tumor is very favorable, especially with the advancement of microsurgical techniques and the very slow pattern of growth. Surgery is curative and symptoms regress afterwards, but the condition may recur if incompletely debulked, but there have been no reports of malignant transformation. So as a take-home message, we have to know that even though Lermidoclaw disease is a grade 1 tumor, its association with Cowden syndrome increases the patient's risk for other neoplasms such as breast, endometrial, and thyroid. Therefore, further imaging and clinical assessment of possible tumors is recommended, and it's advised to recommend this in radiological reports as well as pathological reports. These are the references that we used. And thank you so much for your time, and special thanks to Shefa Al-Orman Hospital for organizing this event. And I apologize for any errors that have occurred. Thank you so much.